Hello, my name is Zubair Baloch, and I will be giving the talk today. And I don't know whether that's fortunate or unfortunate. You have to deal with me for at least an hour and a half because I will be giving both presentations on thyroid cytology as well as thyroid surgical pathology. The surgical pathology one I am going to handle mostly by giving you um, um, we're going to go through some of the cases, and and in the discussion, I will kind of basically focus also on the new WHO classification scheme. So, having said that, so let's start with this, the first presentation, which is about the FNA. So, and I'm going to kind of give you the perspectives on the basis on what I think is important to know. And that will be beyond looking at beyond also the morphology stuff. So, so I just want to make. Do you see my screen? Full view screen?
Yes, I can see it. And
Okay,
Dr. Baloch, before you start, if I can just quickly say thank you so much, everyone, for joining us. We're delighted to have you for another session of the Upgrade Oncology Pathology series, which has been co-hosted by ASCP and Project Pink Blue. Please remember to add any questions to the Q&A box, which Dr. Baloch will answer at the end of our session. And yes, as Dr. Baloch introduced briefly, he will be our speaker today, and he will be presenting on surgical pathology and cytology of the thyroid. So Dr. Baloch, I think we've got a few more people on the line now. So if you wouldn't mind just briefly introducing yourself again, and then go ahead and take it away. Thank you.
Okay. So again, my name is Zubair Baloch. I'm the professor of pathology and lab medicine at the University of Pennsylvania Medical Center in Philadelphia. My expertise includes cytopathology and endocrine pathology. And I'm going to be talking to you about thyroid cytology, which is mostly going to be more of a discussion. And then I'm going to kind of switch to showing you a few of the histopathology cases. And we're going to talk about the new WHO classification scheme, and also talk about commonly encountered and some rare cases to just bring up the discussion about these. So it looks like we have a very limited participation here. It's only 2 of you, but that's fine. And this is going to be recorded, so please tell your colleagues they can always come back, and you can also ask questions, put it in the chat box, as was pointed out by the ASCP staff. So I do not have any conflicts of interest to report for this talk. What I do want to point out that if you look at the thyroid nodules, they are commonly occur in areas which are iodine deficient, but we do see them also in the areas which are iodine sufficient. And in those, there is up to 4 to 7% of US population where there is a lot of iodine in the diet can have palpable thyroid nodules. And if you place an ultrasound on somebody's neck, up to 60% of the population in US have 1 or more thyroid nodules which are not palpable. These are more common in genetic females, and up to 95% of them are benign. So you're dealing with a small handful of cancers. That's why the thyroid nodule screening is there. I do take a lot of shots when I go around and take pictures. And as you can see here, this is actually from Vatican. And in Vatican, there are these pictures. And you can see here, even in this photograph, because the models they used were live models, and those models had goiters. And you can see here a thyroid nodule in this case. So, so these have been there with us for a long time, and they are depicted in these historical paintings. I think I'm going to spend a little time, and I think which is becoming more and more important, that thyroid nodules do also occur in women. And if you are handling those, you are going to see FNAs from those also. They are less common than the adults. They are about 0.05 to 5%, where adults is 5 to 10%. But if you look at the malignancy rates, it's a bit higher in children as compared to the adult population. They're again common in genetic females, and it's actually 1.8% of all thyroid malignancies in the US in children who are less than 20 years of age. So pediatric thyroid nodule, we are learning a lot about them. They are associated with autoimmune thyroiditis, or there is elevated TSH levels. So this is one of the indications that is the association. I don't know whether that's the cause or just an association, but that do occur. The other thing we do have to realize that the thyroid nodules are associated in some of the genetic syndromes. So thyroid nodule may be the only first indication of these syndromes, and these can be benign or malignant tumors. So this list actually is expanding a lot. So I think this is kind of a complex issue that whoever practices thyroid cytology should know about. Now, when you manage thyroid nodule, I think it's all about not just cytologic diagnosis, but it is also about managing thyroid nodule and kind of assessing pre-operatively what is the risk of that thyroid nodule to be malignant. And I put a quote here which says, everything matters, and I think everything does matters, and it starts with the clinical features, lab values, ultrasound features, cytomorphology, where we come in, molecular profiling, where we are involved. And this is something which is naturally is more available to some countries, and some countries do not have this, but I think it does impact of what type of surgery will be done. And then the end result is the management strategy, which I think is basically personalized. You cannot treat every single thyroid nodule the way you treat others. And this also applies to histopathologic follow-up and what type of cancer it will be, and what will be the management strategy even after surgery. So when you look at the preoperative risk assessments, naturally, all these clinical features which are listed on the left-hand side matters. And again, family history is becoming more and more important, not just for medullary thyroid carcinoma, but also for papillary thyroid carcinomas. The TSH, serum TSH, is actually the best indicator of which nodule to biopsy. All the patients in which the TSH is within normal range or is high, that means the patient is hypothyroid, you really do not need to do any other studies, and you can biopsy these nodules. When the TSH is low, that means the patient is hyperthyroid, and the nodule in question may be a hyperfunctioning nodule. In those cases, some of these patients may undergo a radionuclide scan to see if this nodule is hyperfunctioning or hypofunctioning, which in terms will be cold or hot nodules. Now, in adults, the carcinomas in a hot nodule is basically a rare occurrence. That's why those nodules can be clinically managed or may not undergo FNA, because you can imagine a functioning nodule will be very cellular and most likely going to be diagnosed as atypical or follicular neoplasm on cytology. So the goal is to basically biopsy mostly hypofunctioning or cold nodules, which are making less thyroid hormone as compared to the surrounding thyroid. Now, ultrasound is very important because ultrasound is the best guidance procedure to biopsy a thyroid nodule, even for palpable thyroid nodules, because it tells you about the structure of the nodule. It tells you where the solid components are within that cystic or mixed cystic and solid nodule. It tells you about the blood vessels that are traversing the capsule of the nodule or the surrounding, so the patient does not end up with a lot of bleeding. And it also identifies the suspicious areas within a thyroid nodule to be biopsied. Now, there are different risk assessment schemes, and you can see on those, they're all tiered. That means they start at the most or least suspicious and go up to the most, which is the highest suspicious. All highest suspicious nodules have these echogenic foci, which kind of reflects to being psammoma bodies within these tumors, which is suspicious for papillary thyroid carcinoma. Now, why to do ultrasound? As I pointed out, ultrasound provides a guidance for the clinicians to which nodules to biopsy. And I think that is very, very important. Now, and it kind of defines, as I said, which ones are low risk and which ones are high risk. So the clinician and the patient, as well as the radiologist, can work together on which nodules to biopsy. Now, it is the best imaging skill. Now, sometimes you will hear the radiologist saying, or you will hear the patient saying that my nodule was benign on ultrasound. I think that has to be taken with a grain of salt. Sonography can only predict a benign nodule appearance when it is an entirely cystic nodule without any solid component, or is a spongiform nodule with cystic and solid spaces. Most other nodules are either indeterminate on ultrasound or suspicious to highly suspicious. So there's a very limited number of the nodule where a radiologist will be definitely telling you this looks like a benign nodule, and they may choose not to biopsy those nodules. The general consensus is that for an incidental thyroid nodule or an intrathyroidal thyroid nodule, the size should be 1.5 centimeters or greater in a patient over 35 years of age. But I think there is definitely exclusions to these rules. So, so this does apply, but I just want to let you know, similar to cytology, the ultrasound may call only in limited number of cases as completely benign or completely malignant. Now, this is a case of a slam dunk, right away callable as thyroid carcinoma. Why is that? Because if you look at this, so this is the thyroid gland here, that's the isthmus, this is the carotid artery, this is the skeletal muscle, and you see this is nodule which is hypoechoic, that means it's darker as compared to the surrounding thyroid, which is more isoechoic. So that is very typical of cancer, and you see also here irregular margins. Associated with this is a lymph node in the lateral neck. And you can see this lymph node is rounder in shape. It has the same echogenicity as that thyroid tumor. So this is a metastatic lymphadenopathy. Now, so this is a case that the radiologist will tell you that this looks malignant, and because it has those features and plus it has associated lymphadenopathy with it. Now, when you look, because not all the nodules present with an associated lymphadenopathy or has such clear-cut features, there are features on ultrasound that are associated with thyroid malignancy. Solid hypoechoic nodules, the nodules which are infiltrating, they are taller than wide, large and coarse calcifications, and true microcalcifications. It is also important to know what is the experience of radiologist is in reading thyroid ultrasound. Sometimes the thick colloid may appear as echogenic foci or microcalcifications. So it's also important to really understand who is reading the thyroid ultrasound. Now, this is some classic cases of papillary thyroid carcinomas or other carcinomas, and you can see here this speculated appearance, which is due to the infiltrative nature of papillary thyroid carcinoma. So you can see here, this is again the tracheal rings, this is the lobe of thyroid, and you can see this very irregular speculated appearance of this thyroid cancer, which is very common with infiltrative cancers or papillary thyroid carcinoma. Now here you can see, here, this is another one which has these lobated, large infiltrating border. And this is a very hypoechoic nodule, which is very indicative of papillary thyroid carcinoma. This is an anaplastic carcinoma, and you can see this tumor basically takes over the entire thyroid gland as an infiltrative borders. This is very classic of papillary carcinoma because this tumor has that snowstorm appearance of multiple echogenic foci, which is indicative of microcalcifications or samoma bodies. This is another one where you have infiltrative border. Now, this tumor will be highly suspicious for carcinoma, but it will not be outright called as carcinoma on ultrasound because there is an infiltrative border which can be macrolobulated border or very microlobulated, very tiny infiltration. So those features are associated with malignancy. Some of the other ones are calcifications. So large and dystrophic calcifications, and you can see here this big area of calcification, are what is an encapsulated nodule with a capsular calcification which has been interrupted. As compared to this, where there is eggshell calcifications, but these are not interrupted. So this interruption means that this tumor is invading into the capsule. Central and linear calcifications like this are more commonly seen in adenomatous nodules or follicular adenomas. So these are the features which are associated with malignancy. So the combination of these features kind of puts the nodule at higher risk of being malignant. When you look at the follicular variant of papillary thyroid carcinoma versus pure follicular thyroid carcinoma, really there is no difference. They look the same. If you see invasion grossly on ultrasound, then that's good. But as you know, this has to be decided based upon the histopathologic review to find invasion. So that was a little bit about radiology. Now let's talk about the reporting framework. What I will be talking about is most Bethesda system, and this is the first edition of Bethesda system classification scheme, which came out in 2007, published in 2008. And as you can see here, this has 6 different categories. Each is associated with a risk of malignancy and possible management guidelines and how to manage these. It does have a middle group, which is the indeterminate group, which is atypical or neoplasm. Now, based upon these, all of cytopathologists have learned how to diagnose these lesions by looking at the colloid, by looking at the cells, what the cells are doing, and by looking at nuclear cytology. So this is kind of my version of the cases that we have diagnosed at my institution, from benign to AUS, plus suspicious for malignancy and malignant. I think it's also important to understand that the Bethesda classification, even the first edition, came out at the time, was published when there was a lot of movement in thyroid nodule management as well as thyroid carcinomas. So I think the timing of Bethesda classification scheme was actually appropriate for this time, because what we were learning about how to risk assess based on radiology, how to risk assess based on histopathology, molecular profiling of these tumors, and there was a lot of these guidelines were coming out. It's very interesting that if you go back in the literature and up to this date, there are clinical paradigms. Management of the thyroid nodules is based upon how the thyroid cytology is diagnosed. And you can see there's different type of paradigms, and these are from very reputable journals such as JAMA. So what I'm pointing out to you is the success of this classification scheme. Now, when you talk about risk of malignancy for each of these diagnostic categories, it was based upon literature review. And literature is never homogeneous. It's always heterogeneous because it is coming from different institutions, different cytopathology thresholds for calling something benign versus malignant versus atypical, different populations. So that's why this literature is going to be very heterogeneous. That's why we provided the ranges for the risk of malignancy in the first edition. But as we know, when you use those in a real practice, they may not hold true. which means that you may see the risk of malignancies for each diagnostic categories different than what was stated in the book. But that doesn't mean that you're doing something wrong. It just means that it's representing different thresholds, different application of diagnostic criteria, different patient population, and which nodules are being biopsied. So I think that is these studies, which came after Bethesda classification scheme and showed that change in the risk of malignancy are something to be looked at academically, and then you have to decide where you are in this range. And I think that's an important QC and QA tool, but not something to be used that you're doing something wrong, because I don't think it really matters in the end. So I think it's very important to take those risk of malignancy as a stepping stone, but not something which is written in stone. Now, what happened before the second edition? The major change was that what we used to call as encapsulated and non-invasive follicular variant of papillary thyroid carcinoma changed to non-invasive follicular tumor with papillary-like nuclear features, i.e. NIFTP, which is not a benign neoplasm. It's a low-risk neoplasm with basically negligent risk of malignancy. So what this did, it changed the way we looked at the risk of malignancy. Because if you think about what constitutes an atypical or indeterminate cases in thyroid cytology, these cases are follicular pattern lesion with questionable or not so diffusely distributed or well-developed features of papillary thyroid carcinomas, follicular adenomas, or as follicular carcinomas. So naturally, these are the categories which have a lot of these follicular pattern lesions. So actually, when you take out of the equation the non-invasive carcinomas, your risk of malignancies are going to drop. And as it's shown here, as predicted, it dropped in these indeterminate categories of atypical, neoplasm, and suspicious. So one has to kind of think about those things in that term. And this was mentioned in the Bethesda second edition, and it's also going to be mentioned in the third edition, which is going to be coming out by the end of this year or early next year. And as you can see, this has a different table which provides you the change in the risk of malignancy due to making a diagnosis of NIFTP. Because for cytology, the gold standard is histopathologic follow-up. We also gave recommendation as a note that way you can add in your report that this could be a NIFTP, doesn't mean it was a benign follow-up. It was a low-risk neoplasm follow-up. I know it's a bigger concept to come to terms with, but I think it's important to understand that the thyroid cancers, like we managed 25 or 30 years ago, to date are not being managed. The management is very different. More patients are getting lobectomies than total thyroidectomies. Now, this similar also applies to the other classification schemes from other countries, like RCPath, Australian, Japanese, and even Italian. They all have these indeterminate categories. They are maybe named differently, but basically the end result is the same. Now let's go to the fun part of my talk, and that is what really is the matching of the thyroid cytology as to the ultrasound findings and to the histology. And I think this really is important because we do have to correlate what we call on cytology with the histologic follow-up, because it's a learning experience as well as a QC and QA appearance. So let's match this. So a nodule, which is spongiform here, you can see this nodule is very spongiform because it does have these hyperechoic septi plus hypoechoic area. So this will be a benign appearance on ultrasound. This appearance is because of these nodules having a macro and microfollicular appearance, a lot of colloid, which gives rise to this spongiform appearance. As we know on cytology, they show a heterogeneous population of the cells They may have papillary formation, beautiful tissue culture effect. This is a cell block, no nuclear features of papillary thyroid carcinoma, colloid in the background. Colloid, this is a thin prep showing you colloid. So this is compatible with the benign category or an adenomatous nodule. Chronic lymphocytic thyroiditis always gives you a very vascular appearance on Doppler on ultrasound. It is a heterogeneous appearance of equal mix of dark and hyperechoic areas. Because of the lymphocyte will be more hypoechoic, whereas the cells and the vessels will appear hyperechoic. This is the histology, which has oncocytic or Hürthle cell. Now I'm going to make sure that I use the term only oncocytic, which is the new terminology, actually the terminology that is more endorsed by WHO, and infiltration of the lymphocytes in the background and among the follicular cells or oncocytic cells. So this is what we see on histology. And the same findings are on cytology, where you see oncocytic cells, lymphocytes in the background, crushed lymphocytes due to smearing as lymphocytic tangles intermingled with the follicular cells here. And on the thin prep, even if you lose the background lymphocytes, this is very important that you will see lymphocytes also intermixed with the follicular cell groups. So this is a classic case of chronic lymphocytic thyroiditis. Papillary carcinoma shows you echogenic foci, a hypoechoic nodule with an infiltrative border. It has papillae and psammoma bodies on histology, and you make that diagnosis based upon nuclear cytology of elongated cells, chromatin clearing, intranuclear grooves, and beautiful intranuclear pseudo-inclusions like here also. So that is a classic case of papillary thyroid carcinoma. Follicular adenomas or follicular carcinomas will have similar appearance on ultrasound if they are not grossly infiltrative. This is a follicular adenoma. You can see this nodule here with this compressed halo, which is because of the capsule and compressed blood vessels in the wall. It gives rise to, on cytology, a monotonous population of follicular cells, which are arranged in microfollicles, thick colloid, lot of nuclear overlapping and crowding, and no nuclear features of papillary carcinoma. So this will be a classic Bethesda 4 case. Now, Hürthle cell lesions may appear differently, but most look like follicular neoplasms. You will have a monotonous population of oncocytic cells. And as you can see on thin prep, this morphology may change if you're using thin prep, but again, very granular, ample cytoplasm in these cells and prominent nucleoli. Some of these tumors may show what is called the transgressing vessels. That means these cell groups are connected by these blood vessels because these tumors have a lot of vessels within them. They do not have a lot of stroma as you see in papillary thyroid carcinomas. Now, there are some problems when you do cytology. Remember, we were talking about these cases, which are very sizable thyroid nodules, at least 2 centimeters or more. Now, what happens when you have a nodule which is measuring 1 centimeter or less? So when you are making a diagnosis of a follicular neoplasm or Bethesda category 4 on a 1 centimeter or nodule or which one are measuring less than 1 centimeter, you have to be a little careful because papillary carcinomas can be that size. Rare oncocytic carcinomas can measure 1 centimeter or less. But follicular carcinomas measuring that size is basically non-existent. There may be one case report somewhere. Medullary thyroid carcinomas can be 1 centimeter. So before you say that this is a follicular neoplasm, think of intrathyroidal parathyroid lesions or adenomas. They can occur within the thyroid and mimic by a population of monotonous cells, a lot of nuclear overlapping and crowding, papillary grouping, and even blood vessels within them can mimic a follicular neoplasm. In those cases, if you get a cell block, You can do a GATA3 or PTH stain or chromogranin stain. But if you really do not have that, the best test that you can do is take a portion of that aspirate that was taken from the nodule and submit it for PTH analysis, which will be much, much higher than the blood. So these lesions can be silent, may not cause much changes in the PTH or calcium levels because some of these may be non-functioning adenomas, and they can present as intrathyroidal, as a thyroid nodules, and can be mistaken on FNA as follicular neoplasm or diagnosed as Bethesda 4. Now, what is about the single cell atypia or few cell atypia? Remember, the extreme atypical cells in a thyroid FNAs are more likely coming from a benign lesion than a malignant one. The most common malignant tumor that will give you extreme nuclear atypia in an FNA specimen is anaplastic carcinoma, and that will be clinically pretty evident. So when you see extreme nuclear atypia, it may be coming from a case of a nodular goiter, Graves' disease, which has been treated, or chronic lymphocytic thyroiditis. This is one of my cases, which was a 45-year-old genetic female. As you can see, really atypical enlarged single cells. And look at this random nuclear atypia. On history, this patient has Graves' disease, and she was being treated by methimazole on this. And when they did a radionuclide scan, this was all diffuse uptake. There was actually not even true thyroid nodule. This is another case of a patient with breast carcinoma. This is an old case that I always present because I think it's very important to show that some of these cases from chronic lymphocytic thyroiditis can have very atypical cells, but notice the lymphocytes infiltrating these groups. And this was actually marked random nuclear atypia in chronic lymphocytic thyroiditis. So when you see very horrific on atypical cells on an FNA, single cells or few cell groups, think also of a benign lesion. Chronic lymphocytic thyroiditis can also cause chromatin clearing or nuclear chromatin clearing. But do notice all these lymphocytes infiltrating. So whenever you see lymphocytes infiltrating cell groups, think hard before you call this papillary thyroid carcinoma. This case was diagnosed as papillary carcinoma. Patient had total thyroidectomy, and as you can see, this is nothing but diffuse chronic lymphocytic thyroiditis or Hashimoto's disease. Papillary formations. Papillary formation always does not mean papillary thyroid carcinoma. You can see papillary formations in goiter, in Graves' disease, and in papillary hyperplastic nodules, which now being termed as follicular adenoma with papillary architecture. So architecture is not always diagnostic. It's the lesional cell, that cell cytology that is important. So when you're looking at the papillary grouping, which does not have nuclear features of papillary carcinoma, that is not papillary carcinoma, and most likely a benign neoplasm or benign non-neoplastic condition. This is a case of papillary hyperplastic nodule, and you can see here beautiful papillary formations. But if you look at the cells, there are no nuclear features of papillary thyroid carcinoma. And it was actually this beautiful papillary hyperplastic nodule or papillary adenoma. Now, also you have to remember who is biopsying your nodule. And this is one of the reasons that your FNA diagnosis may not correlate with histologic diagnosis. So this is a case of a NIFTP, which has this micro and a little bit of a macrofollicular appearance, basically non-invasive hair. And you can see this area, one of these follicles really do not have such an obvious nuclear features of PTC filled with watery colloid as compared to these groups, which really have these prominent features of PTC. Now, where the needle goes, you may have two different cell groups. So I always ask the radiologist when they're biopsying these nodules to really sample different areas within this thyroid nodules to get a representative sample. And I think that is very important. Again, another case with large follicle filled with papillary groupings which are benign. And if the needle just stays in this area, you're going to get beautiful colloid in the background, follicular cells, and think of benign nodule. But if the needle goes in this area, you're going to get those papillary architecture groups, and you may end up calling this as atypical or Bethesda 3 or Bethesda 4. The other thing to remember that some nodules, when they are biopsied without any gap with multiple FNAs, they may cause infarction or reactive changes in the nodule. So I always say that when you're biopsying a nodule, get the history if this has been biopsied before. Very atypical cells in a thyroid FNA. This was called as compatible with anaplastic thyroid carcinoma. I was very worried about this case because when I was consulted and I said, what is the history? This patient has gone under 2 different FNAs in the course of like 2 weeks. And this sample was taken after 3 days of prior FNA. This is the histology of this nodule, completely infarcted. And if you look at those cells, you notice that this nodule has a lot of granulation tissue, and those cells are endothelial cells, not the follicular cells. So having that history is very important, and especially in cases which are atypical or suspicious for malignancy because of marked nuclear pleomorphism. So what else is influencing thyroid nodule management and our cytologic diagnosis? The thyroid cancers are being managed based upon risk of structural recurrence. That means the low-risk tumors have very low risk of recurrence in the neck. Then there are intermediate risk and high-risk tumors. So this is not about cancer. This is about structural recurrence of the tumor. Also, this has changed on how we do the staging of thyroid cancer. So the gross extrathyroidal extension is required, which is seen by the surgeon in the operative room to switch somebody from T3A to T3B. So this has also changed. Plus, the patient have high preference for lobectomy than total thyroidectomy. One of the reasons is even an experienced surgeon who does many thyroidectomies has at least 6% chance of causing hypoparathyroidism, which is a very complicated issue. One other thing that has managed to really change our thinking about how we look at thyroid cancers is the molecular profiling of these thyroid cancers. So now we know that the papillary tumors with beautiful nuclear cytology of papillary thyroid carcinomas and some of the anaplastic carcinomas are associated with BRAF mutation. Follicular pattern tumors, which are encapsulated, are more associated with RAS mutation. And that really also puts in how we profile these tumors and what additional molecular changes we see in these tumors. And based upon those, you can really assess which tumors are going to be clinically aggressive. Now, this is my view of looking at it, where you can look at the clinical risk for structural recurrence in the neck of a thyroid cancer. Based upon histology and what we see, you can really predict how this tumor is going to behave preoperatively as well as postoperatively. And using those molecular markers, there are commercially tests available in US and in some other countries. I don't know whether you have access to these tests, which can help cytology really figure out whether this nodule is going to be completely benign or it has a higher chance of risk of malignancy. And as you can see, this is one of the studies we did, where if you use the molecular test, the benign call rate really assesses for things that you call Bethesda 3 versus Bethesda 4. So the benign call rate on something that is called atypical is close to 82% when you use molecular as compared to 54% for follicular neoplasm. What does it mean? It means there are a lot of benign nodules that we are calling either atypical or follicular neoplasm. And that really helps when you do these molecular tests. Also, the problem is because now we have NIFTP, which again is not a benign condition, it's a low-risk neoplasm, to really make sure that we do not change our diagnostic criteria for calling something PTC. I think we should stick to our criteria. That's what the Bethesda system gives you, those recommendations to put as an optional note saying to the clinician, I have called this suspicious for papillary carcinoma. And one of this follow-up may be NIFTP, which is a low-risk neoplasm. That doesn't mean you were wrong. It just means the follow-up was different. This is a classic case of PTC, and nobody will disagree with it. The problem, as I was discussing, is you should make sure to stick to your criteria. If you see inclusions, if you see all the other features, it is papillary thyroid carcinomas. And if you do not see inclusions and you see other features of PTC, that is suspicious for PTC. Because the clinicians are taking into account the clinical features, also the ultrasound findings, to decide which type of surgery the patient needs. So because of this, the interesting thing is that when you look at the risk of malignancy for these indeterminate category, it's really different between the Western and the Asian series. So you can see the AUS plus, which is Bethesda 3, the frequency of use in Western countries was 7.7 and 8.4 for the Asian series. But if you look at the risk of malignancy, this was like about 20%, this was 45%. So this is what the geographical distribution of these are. So I just want to point out that this again brings me back to my initial thought that the risk of malignancies do vary between institutions, between countries, and also between pathologists. So, be mindful of that and not think that somebody's doing something wrong. It is totally off the wall or off the charts, then there is something wrong. But if it is in that range, which applies to your institution, then I think you're doing fine. So this is the Bethesda 3rd edition classification scheme, where we're going to have a table for adult patients, and we're going to have a separate table for pediatric patients, because of what I want to point out to you, that when you call a thyroid nodule as follicular neoplasm, suspicious for malignancy or malignant in pediatric age group, the malignancy range can go really low or high, and you can see suspicious for malignancy. So our clinicians in a pediatric age group, when we call something suspicious for malignancy, will treat that patient like having a malignant tumor. So this is again on a high power, the classification scheme for the adults. This is also going to change because how we are classifying our thyroid cancers as per the new WHO edition, which will be the 5th edition. So in the end, everything matters. It's the clinical presentation, the ultrasound risk assessment, your cytology weigh-in, and if you're doing molecular tests, it really reflects to what you are going to see on histology. So I think this is very important to keep this in mind about the preclinical, pre-cytology, cytology, and post-cytology follow-up to really understand. And I think this is very personalized. Some tumors act very differently in different patients. So I think this is where all this data comes in to devise how we're going to manage these patients with thyroid nodule. So this is my last slide. This is how I look at it. I think, again, everything matters. It has to be multidisciplinary to decide what is best for a patient. You cannot treat all of them in the same fashion. So thank you so much for listening to my talk. Now I'm going to go to the Q&A. And the first question was, considering the measurement of a 1.5 centimeter in individuals above 35 years, what is a reference for sonographic diagnosis in children, seeing that there's a high probability of malignancy? So my children's hospital, clinicians tell me, as long they have a cutoff of about 0.1 centimeters. But if it meets any criteria which are suspicious, they will go and biopsy that mass, because to them, because as I talked about, that the differential thyroid cancer risk is much higher in children. Our thyroid FNA-SC, the second question, come in very bloody, quite unlike the clean slice we project. What is your recommendation on sample collection and prevention to prevent this? So the thing is, first is the needle size. It has to be a 27 gauge needle. I don't even like 25 gauge needles. I will tell the clinicians is not to aspirate. So do not pull on the plunger because they can create a negative pressure in the needle because these are bloody specimens. And do not stay in a thyroid nodule for more than 12 to 15 seconds. So they can count up to 12 or 15 and then that's it. So that is the another one. Do not do more than 4 passes. Because after 4 passes, you're going to get nothing but blood because these are vascular lesions. Now, on your end, if you have thin prep available, I will ask them to put everything in the cup and you can do a thin prep and a cell block. If you do not have a thin prep available, ask them do not make smears. If you can make cell blocks or cytospins, then put everything in the cup and have them do this. So I think that is the best way. What I find is handling, because I think it's more operator dependent than the nodule architecture dependent that you're getting a lot of blood on these. So I hope I answered those questions. I still have a couple of minutes. So if you want to, unmute yourself and ask questions, please feel free to do that. I'm sorry, this video that is not working for me on this end. So that's why you cannot see me, but that's the way it is today. So if there are no other questions, I can move to my next talk. I just want somebody to unmute themselves and tell me that is okay.
Yes, please go ahead, Dr. Baloch.
Okay.
Thank you.
Okay, so we're going to now talk about histology. And one of the things I'm going to talk about is the oncocytic thyroid lesions. And why do I want to talk about oncocytic lesions? Because I think they give us the most problems on FNA, on histology. And I'm going to, through this, I'm going to go through differential diagnosis and about the oncocytic lesions, because I think it's very important to talk about these. Because I think they behave differently. They also have different morphology, and they have a lot of things that they can mimic. And a lot of other lesions have oncocytic cytoplasm. So I think this is kind of an important feature. At the bottom, you see 3 big shots, and this is from University of Pennsylvania. We have there are a lot of buildings in Pennsylvania, but old and new. In the middle is the Ben Franklin statue in front of the University of Pennsylvania older building. And if you happen to be in Philadelphia, Philadelphia is a very good and excellent walking city. So please come and visit us when you get a chance. And we can actually even set up time because I love walking through the city and I take a lot of pictures and stuff. So just to let you know that Philadelphia is a beautiful city. So if you are in the US, please visit. Okay. Plus we have an excellent Independence Hall because this was the seat of independence. So these are my presentation guidelines that I'm going to follow. And these are my objectives. We're going to talk about the oncocytic follicular lesions. I am going to kind of touch on molecular profile because it's very important, and talk about the other oncocytic lesions and mimickers. So what is an oncocytic cell? So this is very important to think about history. Now, Dr. Baber in 1876, sometimes we think these things all have been described in the past 20 years. That is not true. They really go far back. So, we are just rehashing and learning new things about something which was described a long time ago. And he actually described these cells in the canines and the thyroid from the dogs. And he said these cells have ample cytoplasm. And this is basically his description with a larger cell with a granular cytoplasm and large nucleus was indicative of this being an oncocyte. So these were described a long time ago. Now, the oncocytic cell itself, the term was coined in 1931 by Dr. Hempel, and thyroid oncocytic cells are actually described by Dr. Ashkenazi in 1898, not by Dr. Hertel, who actually was describing the C cells. And there was something happened in the literature, and his name got attached to Hertel's cell. That's why the WHO now recommends that you call these as oncocytic lesions of the thyroid, such as oncocytic adenoma or oncocytic carcinoma, and do not use the term Hertel. It is interesting that if you look back in the 3rd edition, the Hertel cell tumors were described as oncocytic follicular tumors. But now in the 4th edition, they went back and introduced the term Hertel again, but now the WHO calls them as oncocytic adenoma and oncocytic carcinoma, as you use the same terminology in other organs where you use the term oncocytoma or oncocytic carcinoma. So thinking about the name, the oncocyte, as we know, has granular cytoplasm, round nucleus, and prominent nucleolus. They have been called as oncocytes, oxyphilic cells, and we talked about the term Hertel. There are cells within the thyroid that can have varying amount of cellular changes, and those are described as oncocytic features. And then you have true oncocytes, which we know have sharp cytoplasmic borders and those prominent nucleoli. So one has to kind of think about those terms, and that brings in a lot of differential diagnoses in your head to really think about how these lesions are going to behave. This is cytology preparation, and this is a diff-quick stain on an air-dried slide, which shows you this beautiful granular or denser cytoplasm with very sharp cytoplasmic borders and large round nuclei with prominent nucleoli. And here again, with different staining patterns, you sometimes can see calcifications within an oncocytic group. When you look on cytology, this is a pap stained slide, which is alcohol fixed smear. Again, you see sharp cytoplasmic borders, beautiful round nucleus, and prominent nucleoli. They can be cohesive, they can be single cells, binucleated cells, and sometimes they can lose their cytoplasm and can mimic lymphocytes. I will advise you for those single cells to look at the chromatin, and this is not the chromatin of a lymphocyte. On thin prep, they can maintain the same cytology, but they can also appear like kind of very dark. So one has to be careful when you're looking at the thin prep and have to relearn yourself. When you do pyroglobulin on these cells, you do see that there is a lot of density to the thyroglobulin in the perinuclear area, like dot-like staining pattern. On an electron microscope, they do have these large abnormal mitochondria, which is typical of an oncocytic cell. They are follicular cell derived. That means they make thyroglobulin, but they may make less thyroid hormone as compared to non-oncocytic follicular cells. So going through this, the first thing comes, what is a benign oncocytic lesion or a non-neoplastic oncocytic lesion versus a malignant one? Now, in the pre-operative, remember, I'm going to follow the same theme as how you look at these lesions pre-operatively before surgery. Oncocytic tumors, actually one of those tumors that can also be hyperechoic. Most thyroid neoplasms are either hypoechoic or isoechoic. And we are talking about the echogenicity, that means the brightness of that thyroid lesion as compared to the surrounding thyroid. They can be cystic, they can be oncocytic, and also most oncocytic tumors are PET positive. That's why when the patient is going under PET scanning, they can pick up Wharton tumors within the salivary gland or the lymphocytic thyroiditis or any small oncocytic tumors will light up on PET scan because they have these abnormal mitochondria, abnormal glucose uptake metabolism because the mitochondria are the respiratory units of the cell. And that's why the FTG avid, they are FTG avid, that means they are PET positive. On cytology, you will see a monotonous population of the oncocytic cells with typical cytology, that means prominent nucleoli, round nuclei, can be binucleate, sharp cytoplasmic borders. The other thing to notice is these beautiful transgressing vessels that you see, and you can see here, really collection of these cells interconnected to each other by these vessels. This is actually one of the features which is very typical of oncocytic lesions and is more common in oncocytic neoplasms. Now, this is another view of showing you different cases with these beautiful transgressing vessels. This is actually one of the features that you also see in hepatomas. And hepatomas, when you look at hepatocytes, they look like oncocytic cells. One thing to notice that it is very common for oncocytic cells to have random nuclear enlargement. You cannot use that atypical features to call something neoplasm or malignant because this is inherent to oncocytic lesions. They can also form smaller follicular structures or even papillary groups. Now, when you look at the percentage of malignancy risk, when you call something as Bethesda 4, oncocytic or Hurthle cell neoplasm, it varies by study. Some studies show that the risk of malignancy can be as high as 50% when you call something oncocytic. Others go as low as 16%. So that is all. I just wanted to show you this, what is in the literature about these. Now on histologic diagnosis, when you look at oncocytic carcinomas, most of them are present in the male, genetic males. They are larger tumors at the older age group, and they tend to be hypo or hyperechoic in the ultrasound. So those are some of the features that are prominent in oncocytic. So a male patient presenting with a large size tumor, which is hyperechoic, and you biopsy on ultrasound, and it is an oncocytic neoplasm, the chances of that being malignant sometimes is as high as 50 to 60%. So that is very kind of interesting for these oncocytic lesions. The other thing to note is that the oncocytic cell is the main culprit of being that atypical cell that you see in thyroid lesions. Oncocytic cells on all these things that are listed here, which are all benign, can have very atypical cytology. I showed you these cases which show you these oncocytic cells showing either nuclear atypia or marked nuclear pleomorphism in benign conditions such as chronic lymphocytic thyroiditis. Now let's look at the histology of these. And I think that that is something that also applies to other non-oncocytic follicular lesions. Oncocytic change or oncocytic cells can be focal, like here, in nodular goiter or Graves' disease. And you can see the difference how in the cytoplasmic staining. They can also present as nodular aggregates in the background of chronic lymphocytic thyroiditis. Or they can be encapsulated lesion with this beautiful mahogany color, which is very typical of oncocytic lesions on gross. As follicular adenoma, you can see encapsulated nodule, beautiful margin, no invasion. Now, how do we diagnose carcinomas? This is a table from WHO, and this is going to be also in 2023. All non-papillary follicular-derived carcinomas which are well differentiated, are divided into minimally invasive and widely invasive. The minimally invasive can be diagnosed based upon capsular invasion only. But when you introduce vascular invasion, that means invasion into the vessels in the tumor capsule, they can be less than 4 vessels, which is encapsulated angioinvasive, or with extensive vascular invasion, which is 4 or more vessels. You have to be careful that when you're counting these vessels, you're not counting them in the same spot in different slides, because that kind of defeats the purpose. Now, the criteria is, so these are the same criteria that we apply for other follicular-derived or follicular pattern encapsulated lesions. These are the features here which have been shown to be associated with decreased survival rate in these tumors. Now, when you're talking about angioinvasion, we're not talking about lymphatic invasion. We're talking about invasion of the tumor in the vessels within the capsule of the tumor. Now, this can be direct invasion. You can see this is the tumor capsule. Here is the tumor. It forms like this hook-like fashion, and it invades in the vessel. That is the direct invasion into the vessel, and you have to be very careful in diagnosing this, because you want to see that space of a vessel where the tumor is invading into. Vascular invasion, what I personally really like is the attachment of either a tumor thrombus to the wall of the vessel, which is surrounded by endothelial cells. So there's the tumor thrombus, which is attached to the wall of the vessel, and you have endothelial cells surrounding on all 3 sides. Now, why that is important? Sometimes by just handling that tumor on the gross bench or in the operative room, you can push or dislodge some of the tumor cells within the capsular vessels, which can be pretty large. So to avoid that overcalling of angioinvasion, you have to have this criteria to call something angioinvasion. You can always do immunostains for ERG or CD31 to highlight those endothelial cells lining those tumor thrombi. But I think histology is pretty good. Most cases, you really do not need IHC. Again, I want to bring out what are the features that are associated for an oncocytic carcinoma to have high risk of distant metastasis and other problems. Now, one thing, oncocytic carcinoma can be small. Rarely, but they can be small. They can be 1 centimeter or less. So remember, I was talking about you will not think twice before making a diagnosis of follicular neoplasm in a nodule, which is 1 centimeter or less. But if it's all oncocytic cells, you can call it, because the smaller oncocytic carcinomas do exist. Now, when you look at the clinical behavior of these tumors, by size and stage, by actually size, you can see the Hürthle cell carcinomas, which are less than or equal to 4 or greater than 4. When you compare them with follicular thyroid carcinomas and other PTCs, you can see these do present at a higher stage as compared to their non-oncocytic thing. So this is, we are looking at the 5-year overall survival. So you can see that the survival is kind of a little low as compared to the other tumors. So this one has to be kind of, so these can be aggressive tumors. Now, capsular invasion. A tumor which is encapsulated has only capsular invasion, but no angioinvasion. Can you call it carcinoma? Yes, according to the WHO, you can call them carcinomas. For me, also, capsular invasion has to be diagnosed away from the areas of prior biopsy, that is FNA. The invasion has to be broad-based, and it has to invade in a mushroom-like fashion. When you see just the vertical trickling of a cells in the capsule, you have to be careful, because that could be the site of the prior FNA. So this is different types of invasion, and you can see this actually goes out Actually, I always notice, and I think that is very important to notice, in the area of invasion, the collagen quality of that capsule changes. It becomes much more pinker and denser. And you can see this is broad-based, it mushrooms out and then goes in one direction. So that to me is a true invasion. This is another invasion where you have to be careful. You can have fibrosis within the tumor itself. So you're gonna have to basically draw an imaginary line, find the periphery of this nodule, and you can see how this tumor mushrooms out and goes in this hook-like fashion. This is more of a broad-based invasion, but this is like a part of this really mushrooming out into the tumor capsule. But once you have the vascular invasion like this, then you already know that this is carcinoma. So the capsular invasion is an indicator of malignancy, but to make a diagnosis of capsular invasion, your criteria have to be very strict. There are mimics of capsular invasion. Remember, I talked about FNA. These areas have always have hemorrhage and granulation tissue around them. And as you can see, the cells kind of trickle out because they get pulled out because with the FNA needle. So one will not diagnose invasion based upon this focus or a focus which is close to this. So you have to be away from this area. The other thing that I want to mention is the curling artifact. Do not diagnose capsular invasion at the edge of the cell, at the edge of the section, because there is this curling artifact which can mimic invasion. Oncocytic carcinomas can also have pseudomonas type calcification within the colloid. They are not true pseudomonas calcifications as you see in papillary thyroid carcinoma, but so just be careful that these colloidal calcification can mimic papillary thyroid carcinoma. But when you look at the cells and their nuclei, they are not that of papillary thyroid carcinomas. I think they are different than non-oncocytic follicular carcinomas because oncocytic carcinomas can cause nodal metastases as similar to papillary carcinomas, and they can also lead to distant metastases similar to non-oncocytic follicular carcinomas. They have aggressive clinical course, as I was showing you. The other thing is, which is very difficult for these, is the management. And aggressive oncocytic carcinomas can lose their sodium iodide symporter mechanism to take up iodine to make thyroid hormones. And that may make it very difficult to manage these tumors. And why is that? And I think the reason is that these tumors can have somatic mutations in the mitochondrial DNA, and they may have a very different molecular profile, including higher third promoter mutations, which causes these tumors to be aggressive. So they also have a different molecular profile. They do not have BRAF mutations, as you see in papillary thyroid carcinomas, because there are papillary carcinomas with oncocytic cytoplasm. Now, how do you diagnose them on cytology? Most of these will be called as oncocytic neoplasms. Can you use FNA molecular test to make that diagnosis? That means benign versus malignant. They are very expensive tests. You just have to make sure that it is working for your patients. Interestingly, one of the molecular tests, which is called Afirma, initially really called a majority of oncocytic lesions on FNA, or even having some oncocytic cells, like in a thyroiditis FNA, as suspicious because their molecular profile is very different. So now they have modified, they have a new test, which does much, much better. This is another test, which is called Thyroseq. It's instituted by the UPMC or University of Pittsburgh. And you can see it really differentiates very nicely between a Hürthle cell or oncocytic adenoma or oncocytic benign nodule versus Hürthle cell carcinoma. So the molecular cases can help. Now, what is a differential diagnosis of an oncocytic lesion in the thyroid? The first one is papillary hyperplastic nodule, which is not papillary carcinoma. It's a benign neoplasm with papillary architecture. Now it is in the WHO, it is termed as follicular adenoma with papillary architecture. The cytology can be tricky because it can have well-developed papillae, but if you look at the nuclear features, these nuclear features are not that of papillary carcinomas. You may see groove, you may see macrophages because they can be cystic. On histology, they're very complex tumors which are encapsulated, a lot of papillary formations, but if you look at the nuclear cytology, those nuclei are not of papillary cancer. These are true oncocytic cells which are lining this beautiful papillary formation. So be careful when you get a complex papillary lesion, which is oncocytic, think twice before calling it papillary thyroid carcinoma because you want to look at that nuclear cytology. There is a tumor or a subtype of papillary thyroid carcinoma, which is a Wharton-like papillary carcinoma because it looks or mimics the Wharton tumor of salivary gland. It has papillary formations with lymphocytes in the core of the papillae, but if you look at the nuclear cytology, it's that of papillary carcinoma. These tumors behave similar to classic subtype of papillary thyroid carcinoma. Tall cell variant of papillary thyroid carcinomas. The diagnosis is based upon the feature of 3 times of the length or 2 to 3 times the length of the cell as compared to the width, the nuclear cytology of papillary carcinomas. But what I want to point out that when you're making the diagnosis of tall cell, also look for what is called the tram track appearance, which is the collapsed papillary structures, because where the nuclei look like the tracks of a tram or a trail. So this is called tram track appearance, which is very typical of tall cell subtype of papillary carcinomas. You can diagnose them on cytology also because you can see this really elongated cell. But the bottom line is calling these just papillary carcinomas is okay. On cytology, they do show these beautiful soap bubble inclusions. That means multiple inclusions within the tumor cells. Also think about intrathyroidal parathyroid, which is an oncocytic parathyroid adenoma within the thyroid, and they can mimic oncocytic lesions of the thyroid. You can see oncocytic change in parathyroids, and this can appear after puberty and goes up in the ratio in the older age. So oncocytic lesions are common in the parathyroid. This is an FNA of a oncocytic parathyroid lesion, which has a lot of oncocytes in it, and this was actually an oncocytic adenoma. One thing about oncocytic adenomas, that they may not respond so readily or at that level as non-oncocytic parathyroid adenomas do. So the patient's PTH levels may not be as high as the conventional adenomas. But when you are seeing an oncocytic lesion, which is smaller within the thyroid, think of oncocytic parathyroid lesions within the thyroid gland. Oncocytic carcinomas can also be poorly differentiated. They are aggressive tumors. They have chemionecrosis. They have mitoses, and they can have the nuclear cytology. So you can actually apply the criteria that you use to diagnose poorly differentiated thyroid carcinomas to oncocytic carcinomas. And in the new WHO classifications, these are referred to as high-grade follicular cell-derived non-anaplastic carcinomas. So these tumors tend to be solid and trabecular, have areas of chemionecrosis, like you see in the breast, very marked nuclear pleomorphism, and sometimes they can have this very small cell component with them. So you can see the regular cells, tumor cells, and here the tumor cells have really kind of these darker nuclei, kind of a little overlapping, so almost looks like a small cell component. which is very important in the diagnosis. This is a recent study that came from Memorial, and they said if you are taking a poorly differentiated carcinoma, any form of oncocytic change was associated with decreased disease-specific survival and higher chances of local regional recurrence. So oncocytic cells are bad when seen in tumors, but you can also see them in benign conditions. So this is the outline I followed. And I think it's important to understand that these tumors can mimic other thyroid lesions, and what is the differential diagnosis for these on FNA as well as the surgical pathology. These are the pictures I have taken of Philadelphia. I took most of them during pandemic when I walked to work and I took these. So again, Philadelphia is very famous for its murals, and this mural happens to be by my house. So when you are in Philadelphia, you can actually do a beautiful mural tour where you can see this. And these are the dogwoods that are in the university's city where I work. So when you come to Philadelphia, you will have a lot to do and a lot of sites to see. Now, I am going to continue. I'm going to stop sharing, and I'm going to have a very small presentation on the variants of papillary thyroid carcinomas, because I think it's important to really understand what's happening in the new WHO. So I will take only 10 to 15 minutes for that, and we will have, so is that will work? I think we are still within the time, correct?
Yes, we're still within the time.
Good.
Dr. Baloch, you did get one more question
Yes,
that came
I'm
through.
looking at that. Yes,
Okay,
I'm looking at that
perfect.
question, which is how can one differentiate between neoplastic and hyperplastic lesions on cytology? The simple answer, you cannot. You can say something benign when you have the lot of colloid in the background, your heterogeneous population of the cells, and you say this looks like a benign thyroid nodule, which will include the diagnosis of adenomatous thyroid nodules. Remember, even when you call something benign, up to 4% of those tumors in some lesions on some studies, up to 4% can be malignant. So you can only say that this is a benign thyroid nodule, and you can use that as the Bethesda category 1, but you cannot differentiate it because if this was a follicular adenoma or not. Most follicular adenomas will be called as either atypical or neoplasm. So yes, on morphology, you cannot. Yes, with the molecular, you can. Okay, so I am going to share my screen. Do you guys see my presentation?
Yes.
Okay, good. So this is actually very interesting. And I'm going to go with, show you a case which is very important because you will see them even if when you see the pediatric thyroid nodules, and these tumors do occur even in adults. So this was a 14-year-old female who presents to a thyroid clinic with diffuse thyroid enlargement with a presumed diagnosis of chronic lymphocytic thyroiditis. The outside ultrasound report showed a heterogeneous thyroid with increased vascularity, and she also had right cervical adenopathy. So this is actually the thyroid on the left, which shows you enlarged both right and left lobes, as well as the isthmus. But notice these multiple echogenic foci throughout the thyroid. And this is one of the lymph nodes, which was also enlarged. This is the carotid jugular muscle. And you can see this nodule is this also involved with these echogenic foci. So she definitely has the same process in the thyroid as well as affecting the lymph nodes. This is the FNA. The FNA showed actually samoma bodies, and you can see here actually the sequester of a samoma body with a lamellation, very enlarged cells, a lot of calcific debris and some lymphocytes in the background. And again here, a lot of calcifications, and you can see these nuclei which are cleared out, but forming these kind of larger groups. Here is again this very large group with beautiful samoma body. And then there are really good different population of the cells in there, with gorgeous nuclear cytology of papillary thyroid carcinoma. And you can see this beautiful kind of delicate groove and elongated cells here, and again here. So this was definitely, and again, calcifications in the middle. So a lot of calcifications, lymphocytes in the background, these kind of circular groups of cells, multinucleated cells. So this was actually a mixture of a lot of things going on. This is the lymph node, and you can see now you're getting, now what you're getting is more of these cells forming this kind of have more denser cytoplasm, but definitely intranuclear inclusions, calcifications. Some of these cells have this kind of edematous, kind of cleared out look to them with some more bodies. Again, the cell cytology, which is papillary thyroid carcinoma. So this was called as papillary thyroid carcinoma, and because of numerous samoma bodies, lymphocytes, the solid large group, it was called as diffuse sclerosing variant. This is the follow-up on this, and this is the thyroid gland, which shows you diffuse process, and you can see there's some like fibrosis in it, but there's no normal thyroid left, little bit probably here and here, but most of this is the tumor. This is the histology. The main tumor mass did have papillary structures. So you can see here, fibrosis in the background. And here you can see some of them are solid groups. So let's look at on the high power on this. And you can see these solid groups, which almost look kind of squamoid with numerous samoma bodies, fibrosis, and some thyroiditis. And this is actually a lymph node where you see beautiful squamous metaplasia in these cells. So this is very typical of diffuse sclerosing variant. Now you will see this in children as well in adolescents as well as in adults. Because this tumor is destroying the thyroid gland and causing inflammation, it can mimic the clinical picture of chronic lymphocytic thyroiditis. Patients can present with anti-thyroglobulin or anti-macrosomal antibodies, which is the clinical picture of chronic lymphocytic thyroiditis. This tumor's features were described by Dr. Rosai, who was actually one of my mentors, and you can see these are the key histopathologic features of these tumors. Interestingly, in children, these tumors will behave similar to adults, but when you look in the adults, you can see that what is very important, the distant metastases at the time of the diagnosis are higher, with higher lymph node burden, extrathyroidal invasion, lymphovascular invasion stays the same in these tumors when you compare them with conventional PTC. So they can cause multiple lymph node and distant metastases, including lung, which is the common site. On the molecular level, these tumors have red PTC rearrangements higher than the BRAF, which you see in the conventional PTC. So their molecular profile is also different, and they can also have ALK rearrangements. So by histology and by molecular, these tumors look different, and they can clinically behave differently than your classic PTC. So when you focus now on the new WHO classification scheme, which is coming out at the end of this year or early next year, everything again matters on how we classify these tumors on histology. The prior edition, the tumors were categorized as well-differentiated carcinomas, poorly differentiated carcinomas, and anaplastic carcinomas. And in the 2017 edition, we included the low-risk neoplasm category, which included NIFTP and tumors of uncertain malignant potential. In the 5th edition, the changes happen because our clinical colleagues now think that every thyroid cancer or every thyroid nodule, which is going for surgery, the surgery should be based upon what we talked about on the personalized risk assessment, where the radiology, the molecular profiling, and the cytology helps. So not all patients with a diagnosis of thyroid cancers need total thyroidectomy and radioactive iodine. And as I showed this before, the patient thinking about what type of surgery they get is also changed. In the new WHO, the term variant is replaced by subtype because the term variant is very prolific in molecular pathology. Hurthle cell, as we talked about, is going to be the term oncocytic, and high-grade follicular cell-derived malignancies are now included, which includes your traditional poorly differentiated thyroid carcinomas, as well as high-grade differentiated thyroid carcinomas, which are well-differentiated carcinomas which show necrosis and mitosis. The cribriform modular thyroid carcinoma, which used to be cribriform modular variant of papillary carcinoma, is now just called this because we are not sure that it is a follicular cell-derived malignancy. And the term in the endocrinology now, the term hyperplasia is getting out of fashion because we are finding what we used to call as non-neoplastic nodules are actually clonal neoplasm. And that's why we have introduced the term follicular nodular disease, because multinodular goiter is a clinical term and not a pathologic term. And this really allows the new classification scheme. The cell of origin, the pathologic features, takes into account the molecular profile and biologic behavior. So this is the new classification scheme, which is divided into benign follicular-derived neoplasms, C-cell-derived carcinomas, salivary gland-type carcinomas, thyroid tumors of uncertain histogenesis, and tumors arising from thymic remnants. So papillary thyroid carcinoma subtypes. So now the WHO tells you not to use the term microcarcinomas. Just say papillary carcinoma, give the subtype and the size, because some of those things that were called as microcarcinomas are understood as being incidental and basically non-existing tumor within the thyroid causing no problems can lead to lymph node metastasis and even distant metastasis to lung and bones. So we are discouraging not to use the term microcarcinoma, just say PTC, subtype, and list the size. So based upon this, these are the most common subtypes of papillary thyroid carcinomas, which are on the right-hand side, and they are diagnosed based upon their features, and they also carry a very distinct molecular profile. This is a classic papillary thyroid carcinoma, which should be differentiated from the papillary adenoma or adenoma with papillary architecture. And you can make this distinction in cytology and in SearchPath based upon nuclear cytology. These are other subtypes. This is the tall cell subtype. This is the Wharton that we talked about. And this is the columnar subtype of papillary carcinoma, which looks like a colonic adenomatous epithelium. The other one, which is an aggressive, is the hobnail subtype of papillary carcinoma, which has this typical hobnail cells. But again, nuclear cytology of papillary carcinoma is maintained. So thyroid nodules have been depicted in the literature as well as in paintings. And this is like my version of showing you different paintings and showing thyroid nodules in these models that were used for these paintings. So thyroid nodules are going to stay. I hope that the diagnosis of them by cytology also stays, because it's very important to how it guides the clinical management. So thank you so much. I'm going to stop sharing and look at the question and answer tab. Aliyu asks, oncocytic lesions and PET scan utility in low resource setting with CT scan, not PET. What is your suggestion? My suggestion is if ultrasound is available, it's pretty good. Ultrasound can really at least tell you this is a distinct nodule. And when you combine it with cytology, it means that you've got an oncocytic neoplasm. What I was also mentioning about the PET is PET positivity in the literature always means that this is a bad tumor or a malignant neoplasm. It's kind of associated with it. So just wanted to point out that both benign and malignant oncocytic lesions will be PET positive. So it does not differentiate it because, and also the difference is chronic lymphocytic thyroiditis can be PAD positive also. So yes, so good ultrasound and your cytology is good enough to really make that diagnosis. By histology alone, how can one differentiate an oncocytic adenoma of a buried parathyroid and a follicular oncocytoma? So oncocytic parathyroid will have this acinar look to them. Plus, oncocytic adenomas of the parathyroid will have a rim of normocellular parathyroid tissue. Addition, parathyroid adenomas will have that very dense look with smaller kind of trabeculae with the blood vessels, too many in them. So that will kind of guide you to think that this is a parathyroid on histology. I'm not saying it's 100%, but if you look at those, then you can think it's parathyroid and do IHC. You can actually even do chromogranin, which will be positive in parathyroid lesions. Okay, so I don't see any other questions either in the question answer or chat. You guys have my email that will be available via ASCP, my work email. Please feel free to reach out to me with any email questions, and you can actually email them again in the question and answer or send them to ASCP. I think this is a great series. Please evaluate because that helps ASCP to bring you more sessions in the future to your liking and what topics you would like to really hear. So good luck, everybody, and thank you.
All right, thank you so much, Dr. Bailich, for that great presentation. On behalf of ASCP, I want to thank everyone for attending today's webinar. The next session of this course will be on Thursday, May 11th, covering patholoradiological correlation cases of soft tissue and bone. So please check out our course landing page to register. You can also find recordings of the prior sessions on that landing page. And I think we'll put a link in the chat. So we want to send a special thank you to Dr. Bailich and our collaborators, Project Pink Blue. And we look forward to seeing you all on Thursday. Thanks a lot.
Thank you so much.